Hello everyone, welcome to a new session on immune system disorders. Today in this session we are going to discuss about three important conditions. Out of this, two are of very extreme importance, fine, whose pathogenesis, clinical features, histopathological findings, then spectrum of autoantibodies, everything has to be discussed in detail. And the last one is a very small thing, that is IgG4 disease. So first coming into what is Sjogren syndrome. See, this Sjogren syndrome, it is again an autoimmune disorder. This is characterized by two important clinical findings. One is called as dry eyes. We call it as keratoconjunctivitis sicca. And another one is called as dry mouth, also called as xerostomia. Because of lack of self-tolerance, there will be immunologically mediated destruction of two important glands, that is lacrimal gland and salivary gland. Remember, it may be either a primary, that means it is an isolated disorder, or secondary when it is associated with some other autoimmune disorder. When it is called primary, we call it as Sicca syndrome, and secondary, it is usually associated with other autoimmune disorders like rheumatoid arthritis. Remember, rheumatoid arthritis is the most common autoimmune disorder which is associated with the Sjogren syndrome. Okay, that is secondary form. But some other mixed connective tissue disorder, even SLE, scleroderma or systemic sclerosis. Actually, the word scleroderma is not that much used nowadays. We will use the term systemic sclerosis. Okay, we will use the term systemic sclerosis. Fine? Yes. Then vasculitis, mixed connective tissue disease, or Hashimoto's thyroiditis. Fine. So now let us see the two forms. See, the primary form is also called as the Sicca syndrome. The primary form is also called as the Sicca syndrome. It may be either a glandular variety or an extraglandular variety. Remember, this is not mentioned in Robbins. It is a high-yield info. Remember, glandular. Glandular means what? Mainly affecting the glands. What are the glands which are affected? These lacrimal glands, salivary glands. They are all exocrine glands. Fine. And the patient will present with a keratoconjunctivitis. We call it as dry eye, dry mouth. And remember, when the glandular type of Sjogren syndrome, it is associated with lacrimal as well as salivary gland enlargement. Lacrimal as well as salivary gland enlargement. Okay, due to any cause, we call this as Mikulicz syndrome. We call it as Mikulicz syndrome. So what is Mikulicz syndrome? Sjogren syndrome. In Sjogren syndrome, there is immunologically mediated destruction of salivary and lacrimal gland. But in Mikulicz syndrome, there will be enlargement of lacrimal and salivary gland due to any cause. One of that cause is the glandular variety of the Sjogren syndrome. Then coming into the extraglandular variety. In extraglandular variety, what are extraglandular? That means outside the glands. What are the features? Arthritis. Okay, arthralgia. Most common, followed by synovitis. There will be diffuse pulmonary fibrosis or marginal B-zone lymphoma. Each one of these is an MCQ question. Okay, which of the following are the manifestations of extraglandular variety? Fine? Yes. Okay. Once that is done, we have the secondary form. I have already told you it is most commonly associated with the other autoimmune disease. Out of that, the most important thing is what we call it is our rheumatoid arthritis. Remember, which of the following is most commonly associated with Sjogren syndrome? Your answer should be rheumatoid arthritis. Since the secondary form is associated with rheumatoid arthritis, rheumatoid factor, okay, rheumatoid factor is positive. What is actually this rheumatoid factor? Rheumatoid factor is nothing else but the IgM antibody. What is rheumatoid factor? It is nothing else but an IgM antibody which are directed against a IgG antibody. IgM directed against IgG, we call it as rheumatoid factor. Don't worry, we will discuss in detail about the rheumatoid factor and all the etiopathogenesis of rheumatoid arthritis in that corresponding chapters. Fine. Now let us see the pathogenesis. See, as far as the pathogenesis is concerned, what is the only mechanism that is responsible for this Sjogren syndrome is, I told you, there will be lymphocytic infiltration, like as a result of the immunologically mediated destruction, and finally the lacrimal and salivary gland will undergo fibrosis. This is mainly mediated by two important cells. One is nothing else but what we call it as our CD4 plus T cells, and the second is nothing else but plasma cells, Fine. Yes, remember anti-nuclear antibodies are detected in around 50 to 80% of the patient. Okay, this statement has been given once in a Central Institute exam. Fine, that is anti-nuclear antibodies are detected in how many percentage in Sjogren syndrome? It is 50% to 80%, and we have something what we call it as two most important antibodies which is specific. Okay, specific. Of course, I hope you remember these antibodies we discussed already in SLE also. But remember, as far as Sjogren syndrome is concerned, the most specific what antibodies or what to say, the most commonly implicated antibodies are the SSA, also called Rho, and SSB, also called as LA. They are considered as the serological markers of the disease. So in Sjogren syndrome, what is the problem? There will be aberrant B and T cell activation. Finally, as a result, what will happen? Yes, there will be a normal pathogenesis you can write in all autoimmune disorder. That is a loss of self-tolerance. Yes. Then remember the Sjogren syndrome. This has been asked in 2014 JIBMER. The Sjogren syndrome-like disease. Okay, what is Sjogren syndrome-like disease? Actually, it is not actually the Sjogren syndrome. That means it is not the autoimmune disorder, but as a result of some human T-cell lymphotrophic viruses as well as human immunodeficiency viruses, hepatitis C viruses, the patient may present with dry eye and dry mouth. That is called as Sjogren-like syndrome. That is called as Sjogren-like syndrome or Sjogren-like disease. Fine. Now let us then go for the two autoantibodies. Yes, I told you, we have SSA and SSB. Please just remember this table, Rho and LA. Rho is most sensitive, okay, whereas LA is most specific. LA, okay, remember LA and order. LA is always very specific. Yes, so that is most specific. Then SSA is associated with the what? Early disease onset. How you have to remember early disease onset? A comes first, alphabet followed by B. So early disease onset. Then longer disease duration and extraglandular manifestations. Example like cutaneous vasculitis, nephritis. Okay, I told you, in SLE also we have different antibodies for different varieties of SLE. SLE associated with lupus, neonatal lupus, with any neuropsychiatric manifestation, everything. Similarly, if the Sjogren syndrome, that is as having extraglandular manifestation, it is mostly SSA or Rho antibody, and SSB is most specific. And remember, SSB, okay, it is mainly glandular form. SSB is glandular form. I am writing here glandular form. Okay, glandular form. And remember, the characteristic test you have to do for the diagnosis of Sjogren syndrome is lips biopsy. It has been asked many number of times. It's a VVIP point. Lip biopsy is essential for the diagnosis of Sjogren syndrome. Once this is done, let us go through the morphology. Morphology, this is the part you have to write purely for your theory exam. As far as your MCQ exam, just remember one thing. In Sjogren syndrome, there will be, okay, some 2 points you have to remember. The earliest finding is periductal and perivascular lymphocytic infiltration of the salivary glands. Okay, fine, yes. And then what next? The lymphoid follicle lining epithelial cells, all this will undergo hyperplasia, which will obstruct the duct, and that is responsible for the atrophy of the duct, fibrosis and hyalinization in the later course of the disease. Okay, yes. So, and remember, the patients are at high risk of developing B-cell lymphomas. I told you, marginal B-cell lymphomas. Yes, that is the correct type of lymphoma, which is more common in Sjogren syndrome. And remember, like lacrimal and salivary glands are most commonly involved. It doesn't mean that other glands are not involved. No, it's not like that. So most commonly involved glands are lacrimal and salivary glands. Even the the glands of the vagina, respiratory and gastrointestinal tract, they are also affected. And remember, since there is a dry eye and dry mouth condition, there will be lack of tears. So what will happen? There will be drying of the corneal epithelium, and finally the cornea become inflamed, eroded, and the ulceration. Okay, and remember, in the nose there will be ulceration, and finally it may even causes perforation of the nasal septum. So as far as an MCQ is concerned, you have to just focus whenever they give a clinical history of an enlargement of the salivary gland with a histopathological picture like this. What is this? Actually, it is an intense lymphocytic and plasma cell infiltration. It's not neutrophil, it's lymphocytic and plasma cell infiltration with the ductal epithelial hyperplasia. Okay, what you are appreciating here, okay, what you are appreciating here, this is lymphocytic infiltrate. This is lymphocytic infiltration. Okay, this is lymphocytic infiltration. Okay, I hope you are clear with this. This is lymphocytic infiltration. Okay. Once this is done, let us once again go to the clinical features. I told you keratoconjunctivitis, xerostomia, parotid gland enlargement. Okay, because of the dryness of the nasal mucosa, there will be recurrent epistaxis, recurrent bronchitis, pneumonitis, pulmonary fibrosis, peripheral neuropathy. Okay, all these are most commonly associated with the SSA. SSA means what? Extraglandular. SSB means what? Glandular. Just remember that. Then there may be even tubulointerstitial nephritis, but the renal manifestations are very rare in case of Sjogren syndrome. And I have told you, whenever this is associated with an enlargement of lacrimal and salivary gland due to any cause, it may be any cause, it may be either sarcoidosis or it may be an IgG4 disease, which we will discuss soon, that is also called as Mikulicz syndrome. And remember, around 5%, okay, this percentage has been asked, that is why I have highlighted 5% of the Sjogren syndrome patients develop lymphoma. Okay, yes, okay. And that is the two high risk of associated with what type of lymphoma? Marginal zone lymphoma. Both are MCQ questions, so I am going to highlight it with the blue color here. This is a Q here, okay, this is again a question mark here. Okay, that is marginal zone lymphoma. So whenever you are listening to this, please take your Robbins. I will advise you to take the Robbins, and you also underline and mark all these points. It will be extremely very helpful during your revision. Fine, okay. Then next condition is systemic sclerosis, also called scleroderma. The scleroderma, that term we very rarely use because it is not only a scleroderma means we will always use that terminology with respect to what the skin manifestation, whereas systemic sclerosis, it's not like that. All systemic sclerosis means all systems are involved. Okay, it is almost like a systemic condition like our SLE. Remember, systemic sclerosis is nothing else but as a result of autoimmunity, that is a lack of self-tolerance, there will be chronic inflammation which will cause widespread damage to the blood vessel. And why it is called sclerosis? Because there will be interstitial, okay, there will be progressive interstitial and a perivascular fibrosis in the skin and multiple organs. Fine, yes. So systemic sclerosis means what? There is fibrosis throughout the body. Scleroderma means only with the skin. And remember, I told you, scleroderma, that means that is because skin is the most commonly affected organ, but remember GIT, kidney, heart, muscles and lungs are also frequently involved. Okay, yes. And the patient may finally progress to renal failure, cardiac failure, everything. And remember, we have two varieties. Okay, we have two varieties of systemic sclerosis. One is called as a diffuse scleroderma. That means what? There will be widespread skin involvement. Along with that, there will be early visceral involvement also. Limited scleroderma means only confined to that of the skin, that is fingers, forearms and face. And remember, some of this limited scleroderma is associated with a syndrome. We call it as Crusty Syndrome. Okay, this has been a question. Out of diffuse and the limited scleroderma, it is the limited scleroderma. Okay, they usually have an association like a combination of many diseases, a spectrum of diseases, that is called the Crusty Syndrome. What is Crusty Syndrome? C stands for calcinosis. Okay, R stands for Raynaud's phenomenon, E stands for esophageal dysmotility, S stands for sclerotactyly, and T stands for telangiectasia. Okay, T stands for telangiectasia. Okay, fine. Then coming into the pathogenesis. Okay, coming into the pathogenesis. So just remember this picture. Okay, this picture will itself will give rise to what pathogenesis. Whenever there is any external stimulus or genetic susceptibility. Okay, due to endothelial injury, there will be proliferative obliterative vasculopathy. That means there will be what? Endothelial damage happens. What happens normally? Yes, whenever there is an endothelial injury, there will be cytokines, inflammation, fibrosis. That is a normal mechanism. We already studied in inflammation. Or whenever there is any genetic susceptibility, there will be T cell, B cell activation, which will again produce pro-fibrotic cytokines. Yes, here comes the question: which of the following are pro-fibrotic cytokines? Remember, transforming growth factor beta, interleukin 13, and platelet-derived growth factor. TGF beta causes proliferation of fibroblasts. Interleukin 13 is anti-inflammatory, and PDGF, it causes what? Platelet-derived growth factor, again it causes that is vascular damage. Am I right? Yes, like capillary dilatation, platelet aggregation, all those things. Fine. Yes, so that is PDGF. And finally, all these causes increased synthesis of extracellular matrix, and finally this causes fibrosis of the skin and the parenchymal organs, and even the patient. So this is one of the complication of systemic sclerosis, that is pulmonary arterial hypertension. Okay, pulmonary arterial hypertension. This has been asked as an MCQ question. Which of the following is not a complication? Okay, they have given in that options pulmonary arterial hypertension, then fibrosis of the organs, then skin damage, everything was there. So why I stress pulmonary arterial hypertension means you will neglect. Okay, pulmonary arterial hypertension, the patient will have pulmonary arterial hypertension. Okay, clinical features. Fine. So I have told you TGF beta, interleukin 13, then vascular damage. Remember, as far as vascular damage is concerned, you already know whenever endothelial injury happen. Okay, what is the role? How the vascular damage happen? Finally, there will be fibrosis. Okay, yes. Once that is done, please go through this diffuse scleroderma and limited scleroderma. Okay, yes, we have some spectrum of autoantibodies. Okay, like in SLE, we have lot of antibodies to remember here. In diffuse scleroderma, remember children, in diffuse scleroderma, it is anti what? SCL70. This is also called as anti DNA topoisomerase 1. This is also called as anti-DNA topoisomerase 1. This is the another name of anti-SL70. I am writing here. anti-DNA topo isomerase 1 antibody. Okay, then RNA polymerase 3, anti-U3 RNP, then anti-U3 RNP, that is anti-U3 ribonucleoprotein. This is also known as fibrillary. This has been asked in AIMS once. Fibrillary is present, okay, in which of the following autoimmune condition? Answer was diffuse scleroderma. Okay, this is important. Then in limited scleroderma, you have to remember limited. So there will be cutaneous involvement and there will be anti-centromere antibody. There will be anti-centromere antibody in case of limited scleroderma. Then a table purely for one-liners, okay, in PG entrance exam. What is the most sensitive antibody for scleroderma? Answer is anti-nuclear antibody. Most specific is again anti-SCL70, that is anti-DNA topoisomerase 1. Sometimes both, okay, they may give anti-SCL70, sometimes they give anti-DNA topoisomerase, sometimes they will give both, so you have to mark accordingly. Then associate, so if the system sclerosis associated with the pulmonary fibrosis and PVD means peripheral vascular disease, that is again that antibody is anti-SCL70. As far as systemic sclerosis is concerned, we mainly have anti-SCL. Out of that, most sensitive is anti-nuclear. Okay, yes, sensitive means in the sense what? Yes, using a screening test, that means it is present in almost all individuals. Okay, yeah, this is not only anti-nuclear antibody, it is a characteristic feature of not only systemic sclerosis and SLE, almost all autoimmune disorders have anti-nuclear antibody. And if it is associated with Crusty syndrome, it is anti-centromere antibody. How I used to remember Crust have C, am I right? Crust have letter C. Okay, here centromere also have letter C, so C for C. Then if it is scleroderma renal crisis, yes, this is very important. Okay, this is very important. Scleroderma renal crisis. This question has been asked in JIPMER. Scleroderma renal crisis. Okay, that is RNA polymerase 3. Scleroderma renal crisis associated with which antibodies? RNA polymerase. That is anti-RNA polymerase 3 antibodies. Fine. Okay. And remember, the most common cause of death in scleroderma is also due to pulmonary involvement, probably due to pulmonary arterial hypertension. Let us see the morphology. In skin, there will be sclerosis. That is the first thing. Usually it begins in the fingers distal region. It progresses proximally towards the upper arm, shoulder, neck and face. And remember, histologically there will be CD4 plus, that is you can write the same thing. What? Perivascular infiltrates, edema, collagen fibers degeneration, eosinophilicity, capillaries and small arteries will show what? Endothelial cell damage and the thickening. Fine? Yes. And you know sometimes the I told you, in patients with the Crusty syndrome. Crusty syndrome is nothing else but limited scleroderma. That means they mainly have cutaneous involvement. In such patients, their fingers will have a claw-like appearance, okay, and the face will become like a drawn mask. Okay, these are some of the features in case of limited scleroderma. That means because they are associated with the Crusty syndrome. Fine, yes. And once that is done, in alimentary tract there will be progressive atrophy and collagen fibrous replacement of the muscularis, and the lower two-thirds of the esophagus will have a rubber house like inflexibility, okay, and which may further progress to what? That is intestinal columnar metaplasia. Columnar metaplasia is a predisposing thing for Barrett's esophagus. Then there may be, because of this sclerosis, there will be esophageal stricture. Finally, the end result is that the patient cannot take food because of dysphagia, and there will be loss of microvilli and villi, which is in the small bowel, and which leads to again malabsorption syndrome. In musculoskeletal system, remember, there will be inflammation of the synovium, synovial hypertrophy, hyperplasia. Then I told you, here also you can have the features of rheumatoid arthritis, but rheumatoid arthritis is most commonly associated with the SJOGREN syndrome. Fine. And in kidney, again there will be because of systemic sclerosis, there will be what? The tunica intima of the blood vessel will undergo thickening. There will be deposition of the collagenous material, okay, and acid mucopolysaccharides, and finally the patient may have features resembling malignant hypertension. Okay, that is the BP will be shooting up like anything. Fine, both the systolic as well as diastolic blood pressure. And finally, if you see microscopy, there will be fibrin or necrosis of arterioles, thrombosis and infarction. All these are purely for your theory purposes. In MCQ, nobody is going to ask what is this feature, what is that feature, everything. Just remember, kidney means malignant hypertension findings. Okay, musculoskeletal system resembles rheumatoid arthritis. Alimentary tract means esophageal dysmotility, stricture, rubber hose-like deformity. Then in Crusty syndrome, you will have what? Claw-like appearance, or face becomes a drawn mask. And lungs, remember, pulmonary vasospasm, endothelial dysfunction, finally pulmonary fibrosis. Okay, pulmonary fibrosis, that is one of the most common cause of death because of pulmonary arterial hypertension. Then heart, of course, myocardial fibrosis and pericarditis. Okay, now let us see the picture. See, this is the normal skin. The normal skin. Okay, normal skin. You can see, yeah, here I missed a point. 1 second. Yes. See, there will be loss of retipex. Retipex are some what troughs, depressions and elevation you can see in the dermis. Okay, they are retipex or also called as what reti ridges. Okay, I remember in systemic sclerosis you can see, you can see I am drawing here. See, you can see the reti ridges. Okay, some irregularity. You can see an irregularity. What is this called as reti ridges? Whereas here you can see all are straight, no such reti ridges, and you can see what infiltration, lymphocytic infiltration, and collagen deposits that are lined, arranged longitudinally. So here the finding is loss of reti ridges. This is how you have to differentiate a normal skin from the skin of a systemic sclerosis. Okay, and you can see the extensive fibrosis. Okay, you can see the extensive fibrosis. You can see the extensive fibrosis, and because of that there will be what? Claw-like flexion deformity. What is this flexion deformity called as? Claw-like flexion deformity. Claw-like flexion deformity. And remember, in face it will be like a what? Drawn like drawn like a mask face appearance. Okay. Clinical features, again female to male ratio 3:1. Remember in 70% of patients. So the most common condition associated with Sjogren syndrome is rheumatoid arthritis. The most common condition associated with the systemic sclerosis is Raynaud's phenomenon. There will be episodic vasoconstriction of arteries and arterioles, that to present in the fingers and toes. Okay, and there may be dysphagia, esophageal fibrosis, abdominal pain, intestinal obstruction, weight loss and anemia because of the malabsorption syndrome, because there is a loss of villi and microvilli. Then cardiac dysfunction, proteinuria. Why? Because I told you that is it classically resembles malignant hypertension. Then I told you DNA topoisomerase 1, that is called as anti-Scleroderma 7. Okay, DNA topoisomerase 1. Then we have told about Crusty Syndrome, all those. Fine. Yes, Crusty Syndrome, calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly with the telangiectasia. Okay, that is mainly what? Yes, very good. Limited Scleroderma. Okay, limited Scleroderma. Okay. Then, yes, limited Scleroderma means mainly cutaneous. So again, I used to remember like this: C4C. C4C. Cutaneous means what? Anti-centromere. Crusty syndrome again anti-centromere. Okay, yeah. Then once this is done, at last about IgG4 related disease. It is actually a group of disorders, spectrum. It's a spectrum of disorders characterized by tissue infiltration, mainly dominated by IgG4 antibody producing plasma cells, lymphocyte. It may cause fibrosis, then obliterative phlebitis, that is inflammation of the vein, occlusion of the vein, okay, and increased serum IgG4. It is IgG4 because IgG, we have 4 subclasses, 1, 2, 3 and 4. Out of that, here the IgG4 antibody is producing, okay, the plasma cells and lymphocytes that is responsible for the damage. Okay, see, actually the most important condition which is associated with IgG4 related disease is autoimmune pancreatitis. Okay, very important, autoimmune pancreatitis. But it doesn't mean only pancreatitis will be there, even extra pancreatic manifestations has been found out. Autoimmune pancreatitis. Okay, yes, and even there will be what? Almost all the systems will be affected here also. Fine, and the diseases which are associated with the spectrum are Mikulicz syndrome, Riedl's thyroiditis, in which there will be fibrosis of the thyroid gland, idiopathic retroperitoneal fibrosis, autoimmune pancreatitis, inflammatory pseudotumors of the orbit, lungs and kidneys. Okay, all those not that much important. Just remember 2 points. IgG4 is related with the autoimmune pancreatitis. Okay, that is the one thing which is present, and there will be IgG4 antibody producing plasma cells and lymphocytes, which causes fibrosis, obliterative phlebitis, and usually increased serum IgG4. Okay, will be elevated. You will be elevated in SLE. There will be decreased in complements. These 2 points very important. Okay. So with this we have come to an end. With this we have come to an end of Sjogren syndrome, IgG4 related disease, and systemic sclerosis, also called as Scleroderma. Okay. So I hope that the session will be useful for you. Yes. Okay. Thank you. Please go through all these tables, antibodies. Okay, you can go through my Instagram page. Instagram, that NITHIN Nitin _ Krishnan KRISHNAN underscore PS. Okay, I will be posting daily all the pics from my classes so that you can have a very quick review. Okay, fine, thank you.